Richard Cade. Just a question to either Philip or to Claudia. It is this topic of qualified privilege. I understand when VASM first started off, as it did in Australasia and New Zealand, it was essential to get the surgeons on board so they'd be comfortable with it. You've now succeeded in getting the surgeons on board, and it is essential for our credentialing that we are on board. So I would, for one, be voting to do something about the qualified privilege. And the reason I say that is that as a surgeon at a public hospital, whenever we have a death, we discuss it in our unit, in our specialty group, the hospital, and often outside the hospital to the society we belong to, and of course the VASM, and if you're really unlucky, the coroner. So we have to report to all these groups, and one of the reasons the hospital has to have its hospital-wide study is because they can't access the information from you because of qualified privilege. Now, if qualified privilege is so hard to remove, is it not possible for one organisation that has qualified privilege to be sending it to somebody else, like the Public Hospital Relevant Audit Committee?
So in regards with the qualified privilege, I'm pleased to know that we are making progress. So currently we are working towards changing our purpose, and we will be applying to change the qualified privilege. And what we are trying to achieve is to have a similar protection that VCAM and VSCC has, and the VASM audit would be protected under the Victorian legislation. This, however, did raise concerns within the surgical community. We have already received 2 formal complaints, one from the Victorian Regional Committee and one from the Orthopaedic Association. So we have to be, as I said, very careful to work together. We understand the benefit of actually reporting back to relevant bodies, but we need to ensure that we are forming a forum and a process that potentially allows us to do this safely, and we can truly improve patient care without changing the culture that currently encourages education. So there is changes in place.
Very good.
I understand exactly what Claudia says, that there are a number of surgeons in Victoria who are very resistant to have changes in the qualified privilege, but within the health department they are instituting that there will be new data sets within VAD for the unit of admission, the unit of discharge, and the procedural consultant. And so really within 12 to 18 months, Victoria will be in a position where they can report outcomes by individual surgeon, just as cardiothoracic surgeons have often done, and the vascular craft group already does within itself. I think we as surgeons are much better protected by the VASM process. And if you took qualified privilege away from that, we would not suffer, because VASM has already shown, I think the people who are here today would say our experience of VASM is that, first of all, there's a low finding of preventable mortality. I think 16% is what was in the audit. And usually the second line assessor is very, very sympathetic to the situation that you were in your particular hospital, and the ability to match the second line assessor with a similar hospital and not have the expert from New York reviewing your case is really a success. So I think we'd be better to give up qualified privilege, and I'm really speaking to Victorian surgeons here, than to risk other people feeling a need to start reporting individual surgeon performance on VAD data, which is quite honestly at least 10% inaccurate because of coding inaccuracies.
Thanks, David. Graham.
Graham Dennistein. Philip, I'm sorry we haven't met. I'm ex-VASM myself. I have a long-standing interest in aviation medicine. I was into it before I became an ONG, and I've spoken on this numerous times before. We have to learn from aviation because we're about 35 years behind them when it comes to safety. And the points you raised just brought it all home to me, because I have actually in my professional lifetime seen the changes in aviation safety. And one of the big things, without any doubt, was the introduction of what is known in aviation as the reporting culture. When that came in, it just changed safety almost overnight. And that meant that the pilots would never be in any way disciplined if they reported an incident. They'd only be disciplined if they failed to report an incident. It was a great change in attitude, and that's the sort of thing we've got to embrace if we're going to improve the introduction of the reporting culture. And of course, the analogy between VASM and the Air Transport Safety Bureau is very much alive and well, and is an example of that.
Do you have anything to add to that, Phil?
I think, we have to grasp it, don't we? We have to go over the reports. I think people aren't very happy about filling in forms, but we just tend to not do things very well at the moment. It's all just sort of a bit half-hearted. It's like all the timeouts and that sort of thing that we're doing in theatre. It's a tick box exercise as opposed to actually grasping it and doing it properly. And I think we should be doing these things properly.
We need the cultural change.
I don't know if I can comment very briefly. So I have been working with VASM since the commencement of the audit, so I have the luxury of retrospect. And when we started the audit, we had great reluctance. Obviously, the audit was a voluntary process. And when the surgeons have reviewed the reflective section, most times we would have, no, I wouldn't change anything. Now, looking back, 10 years after, surgeons do feel safely and openly disclosing issues that they would like to improve in patient care. So change takes time, and I think hopefully we are changing culture.
I agree with those words. George.
I'm a non-surgeon, and I guess I just want to strengthen the point that what a hospital does in terms of doing a review of a case is complementary to anything that VASM is doing. So when you're looking at human factors and system safety, the hospital review can provide a much broader approach, the situational awareness of what was going on, that the people involved in it, including the surgeon, may not be able to appreciate. So it's not really adversarial when you're talking from a patient perspective or patient experience point of view. You need both bits of information, the craft group expert opinions, but you also need to know, as a pilot needs to know, going back to that analogy, what's on the ground, what's in the air, what's around the aircraft at the time of the incident. So I know that we've talked about qualified privilege to death, but really we need to think about it as a complementary process and certainly try and avoid duplication as a consequence.
Thanks for that. Any comments? Graham.
Graham Thompson. Although a number of speakers have discussed M&M meetings, I don't think enough emphasis has been given to M&M in this discussion. I think regular morbidity and mortality meetings are contemporary. A lot of the information that we get from VASM and other authorities is delayed. We know from the VASM data that a lot of the problems that occur relate to perioperative care. In a contemporary setting, clinical leaders can educate and change the culture about safety and quality at an M&M meeting. So it's a comment rather than a question, but I'd be interested in what the members of the panel think.
You don't think, Graham, hearing the same stories week after week after week is a bit dispiriting?
I think that, yes, it is, but with a robust M&M meeting, and I think if we go to the gold criteria, where there is attendance by all consultants, and there is a sense of purpose to change the culture in those aspects of poor care, then I think something can be achieved.
Good, thank you. Comments?
I'd fully endorse those comments. It's extraordinary how time passes that the nuances of the situation are quickly lost, and much more important information and perspective is able to be achieved if it's, as you say, if it's conducted in a conducive manner where people do feel relatively free to speak and can comment on all the aspects. It requires a good leader, though, somebody who will encourage and not intimidate and so on. There are ways to try and do this. At the Melbourne, we have a subset. When it looks like it's getting down to, say, more tricky aspects, then the conversation won't be held in front of all the juniors. The surgeons get together themselves and will discuss where they think maybe there were technical breaches, somebody was working outside their scope of practice, things like that, which would be a little more contentious. So it can be, they can be discussed then. But it's an extension of exactly what you're saying. I think it's much better if you discuss it closer to the time rather than something which is done months later sometimes.
Good. David, did you have something to say?
No, I absolutely agree that you need all these processes going on. I think if you were hearing the same stories every week, that's actually, or every month, every year, that means there's a failure somehow of setting strategic goals and actually fixing what the problems are. But fixing problems usually requires diplomacy, face-saving, but getting people to have insight into where the issues are. And many of the problems we're really addressing in our hospitals are multidisciplinary, as you say. And if it's a perioperative care issue, then there's going to be a whole host of people. But it requires an effort to get those people together. And in my surgical safety and quality program, we actually have cardiology involved as well. And the effort to get 3 cardiologists together was actually quite challenging, and there are probably no cardiologists here, so it's pretty safe to say. No, there are. Okay, but getting those 3 people to meet with a professor of surgery and just to discuss what the issues were, and getting them to come and realise this was not going to be a blame thing. This was going to actually be looking to the future. How do we stop this happening? It was a brilliant meeting. But the angst that it caused before we actually had the meeting. And so I think those of us who have leading roles or are chairs of committee or who are concerned, we just have to make sure we put the time in to manage the communication and the perceptions to get a good outcome.
Can you also get anaesthetists and intensivists to your M&M meetings?
Oh, I find that very much easier, but it's because our surgical and critical care program already have those people at the meeting, and they're quite honestly keen as mustard. And if Steve Bolson is up the back. Steve and I have worked on things within Barwon Health, and it's tremendous to have a collaborative approach.
We've done a bit of work on. We've done a bit of work on M&Ms. Not on?
No.
Is that on?
It's flashing.
We've done a bit of work on M&Ms, and I think it's fair to say that one size doesn't fit all. So, for example, I had a recent discussion with our Professor Director of Oncology about what who's relatively new to the organisation, and he wanted to review their M&M process. And I actually sent him among other things, the College of Surgeons M&M guide and some other literature. But their issues are somewhat different, and to a certain extent, it's about case selection for them as much as it's not. You obviously don't audit every oncology death in the way you might audit every surgical death. So I think while it's easy to set, tick box, you have to do this. One size doesn't, from my perspective, one size doesn't necessarily fit all for the M&M process. And I think the other thing we've done is tried to have multidisciplinary M&Ms where there are multiple groups. So we have I know the orthopaedic and plastic surgeons get together, I think, quarterly to look at selected cases. And we have a trauma spine M&M, which has got neurosurgeons and orthopaedic surgeons. So it's a bit horses for courses sometimes.
Thanks. Sorry, Steve.
No, I think I can comfortably echo those comments. We've had no problem whatsoever getting anaesthetists and intensivists into other specialty craft groups, both being invited and being excited to come to bring that perspective where there's been a contributing factor. We have a full spectrum. The horses for courses thing very much applies. In some settings, they're happy to have the nurses and the physios who are involved in the care along to the M&M discussion. In other settings, that's never going to happen. I suspect it will one day, but right now it's never going to happen. So it's very much sits on different structures. The cardiologists, cardiac surgeons come together and they do their M&M together. And they run theirs. They do a review of cases every month. Other groups are running 3 monthly or 6 monthly, depending on the particular craft group. So there's very much a shaping to suit, the craft groups as they are.
Yes, Jason.
Hi, Jason Goh from the Eye and Ear Hospital. Ewan Wallace talked earlier about moving from an era of accountability to an era of professionalism, where the clinicians actually own the data, they have a culture of openness where they talk about it without fear of retribution or blame, etc. And I'm also very inspired by the talks that are given by some of you about how we've successfully reduced mortality. It seems though that the public opinion is that the health system is failing, where if we actually listen to all these success stories, then we may actually temper the opinion of the public and say, well, actually it's not really failing. There are some really good things out there that we just don't know about. So I guess my question to the panel is, do you have any thoughts around how the whole health industry as a whole can actually shape public opinion and it can actually show the public how well some things are actually working in the health system?
Anyone like to tackle that one?
The only thing I can comment on, with the release of every single annual report, we try and have a media release and we coordinate it through the college and we work together with the Department of Health and we pre-warn the minister. Unfortunately, we cannot control the media. What will the media say? We have a media release, we have our clinical director prepared for the interview, we have the Minister of Health prepared to answer the questions. Unfortunately, the twist that the article will have, unfortunately, cannot be controlled by us. So this is from VASM's perspective.
Should we be doing more collectively rather than just as an individual organisation like yourself? As a health industry? Is there something we can do?
I think it's really difficult because, as Claudia says, sorry, that one doesn't seem to be working. I think it's really difficult because we're trying to move into a just culture type approach, whereas the legal system is firmly rooted in a blame approach, and the media is firmly rooted in a let's sensationalise the smallest aspect that looks terrible, let's blow that up out of all proportion approach. So, I mean, we have a similar to what Claudia says. I'm sure all the major hospitals have you take opportunities for their senior clinicians to present good news stories to the media, but the reality is you just don't get the same impact as a bad news story because we come at it from a different perspective, in my opinion.
And the media can often put a negative twist on what's obviously
we can't control the media, and it's just like all the fuss last week with Stephen Duggart's latest report. I don't know whether that was intentional, being a front page of The Age and lots of awkward questions for everybody, and you can't do anything about that. Yeah. They're like children's stories. Anything good news seems to be about children, but adults, there's no good stories, are there?
So, Trevor, it was suggested that what we lack is the denominator in a lot of this, which puts it in perspective. Now, that information is available through VAED. Now, clearly would be there's more expense, but I think it could be money well spent. You can make things look very dramatic, 100 people died of this and so on. But when they realise just how many operations are done, I think it just colours it. So I would encourage every time possible that we do try and get a denominator for all of these procedures so that maybe it'll reassure the public.
Yeah. And there are countless examples where that would help and diffuse everything. Sorry.
John Alcock, I'm Director of Medical Services in Wangaratta and Mansfield. Just a couple of points from the smaller hospital end of the scale. So a hospital the size of Wangaratta by necessity constitutes its M&M committee with a representative of all of the major disciplines. There's certainly a lot of value in having people from outside of just one discipline reviewing your cases, because it's usually the orthopaedic surgeon, but there's always somebody in the room who will point out that the emperor's not actually wearing any clothes, and call into question the combined sort of comfort with what happened. There's also value in having an operational director from nursing in there as well, who can provide the nursing input and can also fight back if people say, oh, well, if only the nurses had done that, it would have gone differently. So I think picking up the comments about having other craft groups involved, it's certainly invaluable, and from a practical point of view, smaller hospitals, it's the only way you can build it. The other point that I'd just make is when you go even smaller into small rural health services, the bulk of the medical workforce is basically your general practitioners. They may be from a couple of practices in town, or they may be even just from one practice in town, and therein automatically lies a problem in terms of having a robust M&M discussion. Years ago, we used to have the LAOS system that was supported at a departmental level. It was a great shame when we lost that system, and a number of us are trying to build up something that looks like that by getting either representatives from the sub-regional, regional hubs to provide clinical governance input into those meetings, or by getting various hospitals together. But it would be great if there was more formal support from Safer Care or the department, again, in that respect, and it is an issue that I'm taking up with Safer Care. Just a couple of points from the small end.
Thank you. Comments? David's gone. Any others? Time is almost up anyway. Yes.
David Deutsch, I'm a surgeon from Ballarat. I just want to touch on what I asked this morning about the good news or things that we do well. We study morbidity and mortality ad nauseum, and it's not inappropriate, but that's only 10%, a small proportion of our activity. Do any of you in your hospitals look at what goes well, or a close shave, and why it became a close shave, and what was successful about it? We had a couple of years ago in Ballarat a postpartum lady who had some sort of vascular anomaly, and she was saved after 32 units of blood and all this sort of thing, and went home with her child. We lost, I believe, an opportunity by not sitting down with everybody concerned to look at what we did and how we did it so well, so that lady went home well with a live baby. And we lost the opportunity to feel really good about ourselves, from the theatre techs through to the surgeons, through to the vascular surgeon, the obstetrician, etc. I'm wondering if we, and there is some data now that safety is not only about learning what we don't do well and hammering the 10% ad nauseum, but learning from what we do well and analysing that. And if I could just go on a little bit, there was a terrific interview a few years ago with, who was the chap who, John Bertram and Paul Roos from Sydney. And they talked about how Sydney performed well. And he told them, this is when they won their first premiership, and he said, look, just go out and play like a good day. Didn't tell them to give 110%, anything like that. And they knew what to do because they'd analysed what a good day looked like. They no doubt looked at what went wrong with themselves and other teams, but their empowering paradigm was go out and play a normal day because they looked at that analysed that so deeply.
From VASM's perspective, we attempted to create a positive case note review booklet. So we have 10 editions of the critical cases, negative cases. We have only one edition of the positive stories where everything what that was done was virtually excellence in service for the patient's journey, even though the patient passed away. For that particular publication, we received the most criticism, and it was the less read documentation that we have ever published. And it took a lot of effort. We actually attended the same presentation, and that gave me the idea, let's try and produce this positive case note review booklet. Unfortunately, it wasn't successful, maybe because people do love to learn from other people's mistake. We will try and attempt to produce another one, but it definitely didn't work for VASM.
I was just going to say that's one of the lessons I've learned through the VCAM process is the important value of morbidity reporting, and particularly when you look at things that perhaps 10 years ago they wouldn't be morbidity cases, and you look at the benefits of the crisis management change and communication training. There's an awful lot of things that are being put in place around human factors and things which are really starting to impact on whether something is morbidity or mortality. And I think encouraging that sort of sharing of how I stayed out of trouble and of the near-miss reporting and learning from why it was a near-miss and why it didn't go through to end up a mortality case that we're reviewing is really important. And sometimes that comes at that big picture level. So I was quite interested in that conversation about M&Ms versus higher level reporting and things. And I think there's a balance where you want all those things in place, because you want the value of all this is in the conversations that happen, particularly between different craft groups and to get change to happen. And you want that happening at individual service levels because you want timely change when it needs to be timely, and when you would need intervention tomorrow, you need that to be able to happen. But then you also need that reporting that goes through at different levels so that you can start to see the patterns and start to see, particularly for a rare event, if it only occurs once in one location, it's very hard to learn from it at a broader level. If there's a pattern of that happening across the state or across the country, then you start to pick up on those lessons that you can learn about how do we keep this from not being a mortality or a severe morbidity case and keep it as a near miss, and how do we share those learnings. So I think there's really important lessons in that.
And it's really an opportunity to be proud as well as learning the lessons. I so often see serious incidents rated as ISR 1 or 2 quickly getting downgraded because nothing happened to the patient, and thank goodness, and that's okay, and we just sweep them away and hide them away. And I think let's conduct the RCO or whatever it is to the nth degree and the successes as well, and then exactly as you say, let's learn how on earth do we get that right, because we don't know how we got it wrong, we don't know how we get it right. Let's try and learn. But I think you're absolutely right. We should stop quickly hiding away the good stuff so that we can focus on the bad things. Let's celebrate it a little bit.
Thanks. I think we might call it quits.